Hi, everyone. I have the good fortune of knowing many of you, but for those of you who are new to us, I am Donna McKay, the Executive Director of Physicians for Human Rights, PHR. And I want to welcome you all to this very important conversation, one that I know we all wish there were no need for, the impacts of COVID-19 on children. This is the 14th in PHR's webinar series examining the COVID-19 pandemic through the lens of health and human rights. We began these discussions to help ensure that medical and scientific voices could be heard, informing our understanding of the contours of this pandemic and informing policies and other responses. And since then, more than 10,000 people, healthcare workers, policymakers, civil society leaders have signed up to hear from experts on a range of topics impacted by this massive public health crisis. Today, we have over 400 people live with us on a topic that focuses on the unique and disproportionate impacts of COVID-19 on children, including physical isolation, the impact of illness of family members, the economic impact of resulting job losses, the health and human rights of children of already underserved communities, and those in immigration detention centers. We'll also look at the interruption of education. A staggering 1.2 billion young people have not gone to school or university in the last 4 months. And all of these new realities will affect their physical and mental health. So that's the subject of today's discussion. And we're really fortunate to have such a wonderful panel to offer perspectives on this topic. So I'm thrilled to introduce today's moderator, Dr. Katherine Peeler. Dr. Peeler is a medical expert at PHR, a practicing pediatric critical care physician at Boston's Children's Hospital, instructor of pediatrics at Harvard Medical School, and medical director of Harvard Medical School's Asylum Clinic. Katie has conducted critical asylum evaluations for PHR's Asylum Network, which provide forensic evidence to substantiate asylum claims of survivors of persecution, including children who seek safety through the complex and restrictive US immigration policies. So thank you for that amazing work that you do, Katie, and I'm going to turn it over to you now to lead this panel.
Thank you, Donna. Thank you so much for hosting this and for having me. I really appreciate it. I actually was counting with my husband last night and realized that I've been volunteering for PHR for almost 2 decades, which is surprising because I don't feel that old, but here we are. So by way of background, I just kind of want to start with some numbers. So last night when I looked, there were more than 9.5 million confirmed cases of COVID-19 around the world. Approximately 2.5 million of those are in the US. We know that children infected with this specific coronavirus are much less likely to go on to develop COVID-19. And globally, children seem to account for around 2% of all COVID-19 cases. But 2% of 9.5 million is not nothing. Rather, it's almost 200,000 children. Most have mild disease, but some, including many children I've treated firsthand in our ICU, have severe pneumonia, septic shock, multi-organ failure. And while we all took solace at first at the fact that at least our kids would be spared of COVID-19, we then learned more recently about the emerging post-infectious inflammatory syndrome that uniquely affects children, and sometimes quite devastatingly, with many children having died, unfortunately. As parents and clinicians, COVID-19 and its pediatric cousin, the so-called multi-system inflammatory syndrome in children, are terrifying. And so as clinicians, we take it seriously. We create protocols and we provide the highest quality care that we are able to. But in reality, the chances that any given child is going to come down with severe medical disease from this particular coronavirus are low. And so instead, I would like to focus our attention today on the other effects of this pandemic on the world's children, the effects that have 100% penetrance on every single child on Earth. Issues like coping with isolation, falling behind in school, going hungry when one's usual free school lunch meals are no longer easily accessible, the much increased stress sensed at home that greatly increases the risk of child abuse, and more. And what about these issues as compounding problems in already vulnerable populations, like children living in refugee camps, those who are homeless, those in detention, or perhaps traveling alone in Central America on their way to seek asylum in a country that has all but closed its border to asylum seekers, namely the United States of America. There are currently thousands of unaccompanied children trying to keep safe in Mexico, hoping the US opens its borders. And while they try to avoid being robbed, raped, or trafficked, they can currently worry about their families back home in countries with blossoming numbers of COVID cases and very little in the way of health infrastructure to treat those who fall sick. There's an overarching sense of unease in all of us, and this is astutely sensed and also experienced by children. With respect to detained immigrant children, the population I am most familiar with, there are other subtle ways in which this pandemic has worsened their health. In the early parts of the pandemic in New York, unaccompanied children in federal custody were on the one hand told that they must shelter in place following the state's guidance. But on the other hand, they were also required to show up in person to immigration court, putting them, their attorneys, and court employees at risk of infection. At other times, tender-aged children, sometimes as young as 5 years old, were somehow supposed to present for their cases via Zoom, with an imposing judge in one box, a translator they'd never met in another, and their attorney zooming in from a third. Can you imagine what a terrifying and confusing futuristic nightmare that would be? In children with deep backgrounds of trauma, this pandemic, our government's disjointed response to it, has only served to add further layers of trauma. Our speakers today are four incredible women that I'm honored to share this moment with. They come from varied backgrounds with diverse and interesting perspectives on child health, motherhood, community engagement, and activism. Each speaker will lend her voice to an aspect of the pandemic that has affected children. Given the variety of topics that they are covering, the second half of this webinar will serve as an open discussion. So please feel free to submit questions as we go along, and we'll get to as many as we can. So without further ado, I would like to introduce our first speaker, Dr. Kimberly Montez. So Dr. Montez was recently in Boston, but we lost her, and the great state of North Carolina is currently benefiting from her care. She is the Vice Chair of the American Academy of Pediatrics, or AAP's Council on Community Pediatrics, and also a practicing general pediatrician in Winston-Salem, North Carolina. So Kimberly, I'll leave it to you.
Hi everyone, I'm so grateful to be with you today to share my perspective. As a community pediatrician, I wanted to talk about a few important ways that COVID-19 is impacting children and families in the community that I live and practice in, which is Winston-Salem, North Carolina. Unfortunately, we've seen a disproportionate impact of COVID-19 on Latino, Hispanic, African American, and Black populations. For example, Latino people make up 13% of my county's population, yet they account for over half of the people who test positive for COVID-19. These communities are already vulnerable to racism and the negative impacts of the social determinants of health, like poor access to health care and transportation, interpersonal violence, immigration-related legal issues, and food insecurity. Latinos and African Americans are also more likely to work low-income frontline jobs and don't have the privilege of working from home. In particular, the Latino population was already living with fear, uncertainty, and discrimination prior to COVID-19 due to immigration policies, which have worsened in the context of the pandemic. For example, the recent public charge rule only applies to individuals seeking admission to the United States and those applying to become lawful permanent residents, also known as the green card. It provides grounds for inadmissibility if these individuals receive one or more public benefits, like cash assistance, housing assistance, and Medicaid. However, WIC, Women, Infant, and Children, the Children's Health Insurance Program, these do not apply. But it's a very confusing rule, and we've seen how it has created a chilling effect. That is, immigrant parents of US citizen children are choosing to forego benefits for the entire family out of fear, even though public charge doesn't apply to families with US citizen children. A recent report by the Urban Institute revealed that 1 in 5 adults in immigrant families with children reported that they or a family member avoided a public benefit for fear of risking future green card status. This includes important nutritional benefits such as SNAP or food stamps, as well as Medicaid. We've seen large declines in visit rates at my own clinic, where 90% of our patients have Medicaid and 67% are Latino. Parents are understandably worried about visiting the pediatrician's office out of fear of becoming infected, or unfortunately using Medicaid because of public charge. But vaccination rates are dangerously low. As states are easing restrictions, I fear there may be outbreaks of vaccine-preventable diseases such as measles. For children who have cancer or are born with abnormal immune systems, it's imperative that children with normal immune systems receive their vaccines on time to create herd immunity, which provides indirect protection to those who cannot receive vaccines. If you're a parent listening and you've chosen to delay your child's vaccines because of the pandemic, please call your pediatrician today. Most offices are following strict safety and sanitation protocols to limit exposures. Another thing that I've seen in my community is an increase in food insecurity, which means families have limited means to purchase enough food to feed their families nutritious meals. Now, more than ever, the pandemic has exposed the inequities of childhood hunger in the backyard of our first world country. Families that struggled with hunger before the pandemic have been disproportionately impacted by job losses, school and childcare closures, and an overwhelmed charitable food system. Even before the pandemic, food insecurity rates were unacceptably high in households with children. In my county, 1 in 5 children suffered from food insecurity. Now, in a recent national survey, 42% of respondents and children reported that they worried about running out of food. The time to advocate on behalf of children and families is now. Children are depending on us. Thank you.
Thank you so much. Thanks, Kimberly. Our next speaker, I'm also excited to introduce, Dr. Sabreen Akhter, she's a pediatric emergency medicine physician, actually, in Seattle, at Seattle Children's Hospital. She also serves on the medical team for the Pediatric Emergency and Critical Care Kenya Fellowship, and she's also recently written several op-eds in the Washington Post that I encourage all of you to Google. They're very well-written reflections about what it's like to practice medicine and just to live in this current time. Sabreen.
Thank you. Thank you so much. And thank you to PHR for giving us a platform to talk on these important issues. And thank you so much to Kimberly for that amazing bit of information. So just kind of as a background, I practice in Seattle in the emergency room here. And we were, very well tuned to what was happening, mostly because we were kind of in the area where the very first outbreak in the US was happening. And so, there was a lot of disaster planning and surge planning that went into kind of coordinating between hospitals here. And thankfully, we didn't really see a huge impact of the disease itself in terms of infections to children. And that having been said, as so many on this call have already elucidated, we have seen so many downstream effects that have been affecting children. Some of the things that we're seeing currently are continued really exacerbations in mental health issues in the children that we're seeing, really high rates of anxiety and depression and suicidal ideation and attempts really. And Dr. Peeler was kind of talking earlier about how really our ICUs have been seeing high rates of really serious ingestions. And I think kind of confounding just already being isolated and depressed is the inability to really access mental health care that we're seeing. So for some children, Zooming into their therapist or psychiatrist works really well. For others, particularly who are younger or non-neurotypical, we're seeing that they're really struggling with this time. The other things that we're worried about, that we're kind of just noting anecdotally that we don't really have numbers to yet, but that we're anticipating would be really high rates of child abuse. We have seen this previously in the previous recession in the early 2000s, and we anticipate as children are at home for longer periods of time, and just as we anticipate higher rates of domestic violence towards women, we anticipate kind of the same happening with children, and we're already kind of anecdotally seeing that appear in our emergency rooms as well. As Kimberly had spoken to as well, there's so many health effects that kind of exacerbate already prevalent inequities in our culture, and the loss of childcare, especially in families of color or kind of families with more traditional backgrounds who really depend on that generational childcare, especially as there are much greater losses to Black and Latinx families. We're seeing huge problems with that. We're also seeing just increased rates of food insecurity with being away from school, and not just food insecurity, but kind of widening gaps in educational abilities, especially as children are homeschooled, potentially homeschooled by families who are essential workers who can't really be with them, and also just access to Wi-Fi, to computers, to tablets, to internet, that again is going to exacerbate inequities in our system. And then the last kind of point that I wanted to make, just as we kind of think of the ethics of COVID and who we decide to, offer life-saving treatments to, Right now, we're not having to really make these decisions specifically with children, but especially as we enter the fall and we start seeing our health systems really getting to the breaking point again, and I know that's already happening in different parts in the US. You know, there was a New England Journal of Medicine article that kind of pointed to stratifying sort of who we should potentially think about providing care to if we're really at that breaking point in a pandemic. And the point of the article was really to take the burden and the onus off of providers to make that decision. But I just want to kind of complicate the idea a little bit by thinking about if we're only thinking about providing life-saving care, such as intubation, critical care beds, space to folks, elderly folks who are, you know, not with that many comorbidities, particularly diabetes, coronary artery disease, asthma. Those are often the kinds of problems that we see in communities of color. And it will serve to then kind of worsen and really deepen some of our racial inequities that we already see. So it's just a point to think about when we think about the ethics of who we decide to provide care to once our systems are at their breaking point, which I fear may come again in the fall. But thank you, and I'll yield back to Katherine.
Thank you, Sabreen. Those are all great points. I'm sure we'll have a lot of questions about that. The ethics one in particular has come up a lot. One of the ethicists at our hospital has written a lot about the crisis standards of care in Massachusetts and globally, and I think had a lot of feedback with what you were saying on his original thoughts, and so we can talk about that too. Our third speaker, I'm really excited to introduce. She's amazing. Her name is Laura Alderman. Laura is the executive director of Step Forward, which I will let her explain a little bit more, but is a wonderful nonprofit in Shreveport, Louisiana, which is a part of a larger nonprofit around the country that essentially serves to try to promote the development of youth from cradle to career. And I'll let her kind of go in a little bit more to that. But she's a licensed child and family therapist, and she's conducted training on childhood trauma for hundreds of professionals and its educators. And she's going to talk to us a little bit about a pretty incredible initiative that some people that she works with have done and what it's going on now. Laura.
Thanks, Katie, and thanks, PHR, for this opportunity to talk with you today. I'm assuming you all can hear me. Okay. Yep. Okay. Awesome. As you may have surmised, I'm the only non-physician on this panel today, so I consider it an honor to be included. I'm excited to tell you a little bit about our work. So our nonprofit organization does work toward the mission of ensuring success for every child. And we do a lot of examining data, local and national reliable sources of data to give us a baseline for where the work should begin. And we primarily are focused on 6 core academic indicators, but what we know is that those are really driven by some contributing indicators and social emotional determinants. So I want to tell you a little bit about a group that we convened about a year ago, and that was our Teen Advisory Committee. So this is a group of amazing teens from across Northwest Louisiana who were willing to come together and work to share their expertise with us. And we really do consider them experts on what it is like to be a young person in our community in 2020. Everyone else is just guessing. They actually know firsthand. So we asked them to tell us what their major concerns were. And not surprising, they identified student mental health as one of their primary concerns. And not only did they tell us that this was a concern for them, but they wanted to do something about it and to understand it in a deeper way. So they came up with a plan to survey their peers, and surprisingly, our public school district gave us permission to administer their survey to all high school students. There were more than 5,000 responses. Nearly 50% of the entire student body in this public school district responded to the survey. And what they told us was that 73% of them indicated they experienced some type of emotional distress in the school setting. Yet fewer than 10% seek support from school counselors. And so there is quite a disparity in the need and the supports that are sought. So in response to that survey, the Teen Advisory Committee convened a teen summit on mental wellness, and they planned this for months. It was planned to be executed on March the 17th, and on March 15th, all schools closed, and we were not allowed to gather in public settings. So they very quickly pivoted and created a platform on Zoom, and they brought together 72 student delegates on a Zoom call that lasted for 4 straight hours. What they did during that call was absolutely amazing, and it is recorded in case anybody wants to see what they did in action. But the outcomes of that convening were that the attendees developed a list of policy recommendations for 2 of our largest school districts, potentially impacting 75,000 students. And these were some of the recommendations that they came up with. They very wisely landed on strategies that were really very low cost. I think they anticipated that every dollar was going to matter in the very near future. And so you'll understand, I think, that some of their strategies could easily be implemented by any school district. So they wanted improved training for all teachers on how to respond to student mental health concerns. They wanted to see wellness strategies integrated into their school day, including things like mindfulness. They wanted to use their mandated health class to teach mental wellness strategies to students. They wanted weekly interactions between counselors and students to build that relationship. They recommended maintaining the same counselor and same student from 9th to 12th grade. They wanted to create a confidential virtual referral form for students to see their counselors, and they wanted protected time for school counselors that was devoted to mental health support only. So I think you can see that a lot of this work is very applicable to where we are today, regardless of what the school setting looks like in the fall. I think we can all agree that there's going to be an increased need for mental health support in response to this level of toxic stress that we are all experiencing. And I just want to say we are all quite amazed with what our teams have done with this opportunity. And I want to encourage anyone listening, talk to the individuals who are most affected. Understand from them what they need and how they need it delivered. They have much to teach us. And I'll stop there.
Laura, thank you. I have a lot of comments and questions, but I will reserve them.
Okay.
Great, thank you. So our next speaker is Jyotsna Bhattacharya, who is a dually trained pediatric hospitalist and pediatric infectious disease expert. So a great speaker to have on this panel. And she is a physician at Kings County Hospital, SUNY Downstate Medical Center in Brooklyn. So clearly an epicenter of this pandemic, and serves as an associate program director of the Pediatric Hospital Medicine Fellowship there. So Jyotsna, take it away.
Great, thank you, Katie. Thank you for having me join this important conversation. I've lived in New York for 12 years, worked and trained in 3 different institutions in 3 different boroughs. What has become clear to me during my professional journey is that there are indeed these exclusionary forces and inequitable human conditions that likely prevent African Americans, Hispanic, minority women, and their children from securing health benefits that are characteristically associated with upward socioeconomic mobility. My questions to myself, especially since the COVID-19 pandemic, and to my colleagues is, are we discussing these inequities enough? In fact, living in New York, one of the hardest hit states, how can I have meaningful discourse about COVID-19 and not have racial inequities be at the center of the experience or the center of the conversation? How we essentially articulate the pathologies of our societies, COVID in New York, for example, directly informs our behaviors, our actions, our policies. Now, as pediatricians, we know that children of racial minorities suffer a disproportionate burden of morbidity and mortality. Example, CDC Grand Rounds 2017, they note that stressors, which our minority populations face in early childhood, can disrupt neurologic, metabolic, immunologic systems, leading to poor developmental outcomes. New York State has one of the highest maternal mortality rates in the country, especially with Black women, who are 3 to 4 times more likely to die from complications arising during or after childbirth. In New York City, Black women are 12 times more likely to die from complications arising during or after childbirth. The data also tells us, for example, that there are increased odds of mortality in neonates admitted with sepsis from low-income families. This may be due to an access to a tertiary care center, lack of transportation leading to increased severity at presentation, even hospital quality. Working at a county hospital that serves a 94% Black population during the COVID-19 pandemic has really changed the way that I contextualize every interaction with a child. And really, it's made me reconsider every conversation with a resident or a trainee about their future aspirations and how to sort of get there. We know, again, that particular racial groups have a long history characterized by retributive injustice, economic exploitation, systemic displacement, or this geographic marginalization. And so what does that mean for us as pediatricians? Basically, optimal longitudinal care will depend highly on individualized care based on the current social context. In terms of retributive injustice, minority patients and their children, who are our patients, face a systemic violation of their civil liberties with impunity, and we're seeing that now. So our patients will rightfully scrutinize the intentions of those of us in positions of relative power and privilege. In a national survey that was conducted by NPR and Robert Wood Johnson Foundation and Harvard T.H. Public School of Health, they had noted that over 1 in 5 African American and 1 in 6 Hispanic respondents reported that they had avoided seeking medical care for fear of discrimination. So how do we expect these children and these adolescents to view us, a privileged authority figure, when we dole out our anticipatory guidance? So this, I think, requires our collective thought. Have we prioritized establishing real trust with our patients? Do we recognize that establishing trust with all our patients in a post-COVID-19 era cannot be this pan-universal approach to children of all races? And I say this because COVID-19 has seized the lives of many of the loved ones of our Black and Hispanic young patients. Will we go into these communities of our patients to see that mistrust exists and try to understand why it exists? Are there physicians and researchers in your group that share a cultural background or history with the community you're working with? And do you draw upon their knowledge? To my second point with the economic exploitation of the families of our patients, we have to be cognizant of the systems in which they live. There are a multitude of ways, as we all know, in which minorities have been the backbone of dominant culture capitalism. To this day, people of color remain a staple in low-paying domestic and service vocations. One poignant example of what I think of as sort of the privilege of professional and economic self-defense is with the U.S. Equal Employment Opportunity Commission, the EEOC. It was created in 1965. Its mission was essentially to enforce federal laws that made it illegal for employers to discriminate, discriminate employees based on race, color, religion, sex, national origin, age, or disability. So from 1980 through 2018, the US population has grown by 44%. Despite its growth, Congress has not really meaningfully increased the budget, meaningfully increased the budget. And in 2018, there was an accumulation of 50,000 charges of discrimination. And now think of our patients and families that fear that retributive injustice I mentioned earlier, and how many cases have never even seen the light of the day of the EEOC. And I bring this up because jobs are one of our only means of economic stability, or especially for our patients, asset development, or hope for creation of generational wealth, which they have not historically had. Now with COVID-19, Black and Latino patients have been affected the most by stay-at-home orders because of their privileged inheritance, tongue-in-cheek, of occupational segregation. So essentially, these parents of the children that we see in our emergency room, our inpatient floors, our ICU, are overrepresented, again, in these low-wage, at-risk, essential worker jobs that can't transition so easily to remote work. So if the parents of some of our families are possibly experiencing chronic stress due to economic hardship, then how will we manage their children differently going forward? Again, this requires our collective thought in all the different settings, ED, inpatient, ICU. Should we be asking the patients more about their economic hardships to understand the role this may play in their children's lives, how things have changed in the past few months? And should we be rethinking the role of social work and community partnerships during this time and encouraging our institutions to devote more resources to these fields? Should we be creating more tailored well-child visit follow-up timelines in children at risk for the morbidities associated with low socioeconomic score? Do we need to advocate for our insurance systems to help support such an initiative for more frequent visits? And finally, to my last point on geographic marginalization, children of color, as we know, are more likely to live in densely populated urban areas and or crowded multifamily housing residences in areas where there are food deserts. Their parents, grandparents, extended families are at increased risk of infection from coronavirus. We know this, in severe disease. Many of the parents and children in our hospital, just in speaking to these families here in Brooklyn, report knowing anywhere from 5 to 12 to 20 people that have died, have been affected or died from disease. And this is just a staggering number and very different from the experiences of children in other communities and other parts of the city. A 2017 study in the Proceedings of the National Academy of Sciences had analyzed nationally representative data sets to compare Black and white Americans on the likelihood of losing family members over their life course. And the study indicated that Blacks were significantly more likely than whites to have experienced the death of a mother, a father, a sibling from childhood through midlife. And that the hardship faced by these children has disparaging effects on Black families, Hispanic families, and communities. So this public health emergency, in this public health emergency, our children are currently undergoing, they're undergoing tremendous stress, whether they discuss it or not with us during our time with them at the hospital. So do our children, the questions I posed from this, do our children of color need more support from us pediatricians now? Again, this deserves thought. Is being race neutral, so to speak, with regards to our yearly well-child visits? Are those follow-up plans still appropriate, given that we may miss a year's worth of physical and mental downstream effects, like had been mentioned earlier, of racial inequity that only some of our patients will singularly face during the COVID-19 era? Have we recognized the need of our children's increasing mental health services, as you had brought up earlier, in the ED, in the inpatient setting, in the clinic setting? And again, will we advocate for more frequent visits or televisits to assess for mental health and well-being of children that we may not have done before? So I think we need to start rethinking of the ways in which we, as primary and specialty clinicians, sort of begin to actively discuss and engage with our patients and families in different inpatient or outpatient settings. Essentially, I mean, my hope is that we sort of collectively and with intentionality take part in breaking down sort of the structural racism that has been highlighted most recently with COVID-19 and will continue to be highlighted over the ensuing months.
Thank you. No, that's great. And that's like a good segue. We have a lot of questions from various people in the audience and that I've written down furiously as you've all been talking. Some questions are a little bit more medically heavy, some are more policy, some are kind of about activism and structural racism. And so these are in no particular order, but this is for Kimberly. You'd mentioned the decreased rates of people coming for vaccination, and the real appropriate worry that we might have another pandemic of an actual vaccine preventable disease if we don't get back to our vaccination rates that we were at previously. The question is, knowing that there's not a vaccine yet, but let's operate under some ideal situation that we have a great vaccine in the future, whether it be 1 or 2 years from now. Are there any worries amongst community pediatricians or potentially the AAP, if you're able to speak to that, about the distribution of a COVID vaccine, like is that going to be distributed equally and in a just manner to all children? And the other question is, has there been any discussion about whether or not, and I know the AAP does not decide this, but it's optionality, right? Like a lot of vaccines are required by schools, but flu vaccine doesn't tend to be. So what about the coronavirus vaccine? That's going to be, and how are we going to educate our parents and families about this vaccine when it comes out? That's a lot. So answer what you will. I mean, I know a lot of it is speculation at this point.
Sure. Well, I have hope that a vaccine would be administered or provided equitably. My worry, however, amongst at least clinics and practices, my worry is the fear that the families have about the virus itself, and therefore the vaccine as well. And in addition, are worried even just to come get recommended vaccines already. And we're seeing, like I mentioned, the decrease in visits. So I mostly worry about the fear that our families have about this virus and getting the vaccine more than the equitable distribution of it. And so I worry that families will self-select not to receive it. And so I think as pediatricians, we must harness the relationships that we've built with our families, particularly as community pediatricians. That is the strength that we have. And also proactively reaching out to our families to educate them. We've heard about all of the disparities related to access to healthcare, as well as who can stay at home and who can't, and access to internet. But I really do think it's the medical community's job to proactively reach out to these families, hold community events, work with community partners, visit schools, form coalitions with community-based partners in order to provide this very important education. And you had another question, and
no, I think it was mostly, it was about the distribution and then the barriers to getting, or the optionality. I mean, I know you can't answer that, but that is one of my fears, the flu vaccine is optional. At every school district is different in terms of the percentage of children. Just in Massachusetts, we got an announcement yesterday, or at least in Cambridge, really encouraging people to get this year's flu shot for fear that the compounding effects of the fall coronavirus surge with the flu is going to be both dangerous for children as well as for the teachers who are going to be braving potentially coming back to school in the fall. Another kind of semi-related question. This one I think could be probably for Jyotsna from an ID perspective, but Kimberly, you're also welcome to comment. So Kristen Auerbach, who's actually one of PHR's board members, had asked, with schools across the nation deciding how to open later this summer and fall, should teachers of very young students, ECC specifically, be encouraged to wear masks or clear face coverings so students can see facial expressions of their teachers? Also, should children under 12 be wearing masks while playing outdoors in hot weather?
Okay, in terms of masks, I think targeted efforts to reduce, prior to schools opening, targeted efforts to sort of reduce social interactions definitely appear to have succeeded. In terms of surgical masks, they were really originally designed to help prevent really contamination of the work environment, their environment around you, or a sterile field from these large particles that are generated by the person wearing them. And again, we're seeing even just the surgical masks have contributed to, again, sort of limiting spread of disease. So I do think masks should be worn. And in terms of the material, if we're able to sort of have a material where we're able to still be able to see facial expressions of teachers and children, I think that would absolutely be ideal to sort of this new sort of stage of this impersonalization, which has been happening over the past couple months, certainly.
I can talk just briefly. I wanted to mention an excellent resource that is hot off the presses, and so you can actually, if you have more questions about it, you can just Google it. The American Academy of Pediatrics, of which I'm a member, just released COVID-19 Planning Considerations Guidance for School Reentry. unfortunately, we still don't know a lot about how the virus is transmitted amongst children. And so we're still learning more about that. But in particular, the recommendations for the pre-K was that the high priority strategies you should minimize crossover between children and adults within the school, and you should utilize the outdoor space as much as possible and limit visitors in the building. Particularly for the face mask coverings, they say that the AP recommends that it may be very difficult for those of you who have young children at home. Like myself, I have a 2.5-year-old, and it's just impossible to get her to keep wearing her mask. And actually the AAP doesn't recommend masks for less than the age of 2 anyway. But it's probably difficult to implement. And so reducing classmate interactions and play in the school, it may not provide substantial COVID-19 risk reduction. So hopefully that answers a little bit of your question. It is outlined by pre-K, elementary schools, secondary schools, so that may be helpful to look up and read.
Thank you. Laura, I had a question. Actually, it's building off of something that Sabreen had mentioned, which was the loss of childcare for a lot of different families. And you had written, not to plug everyone's op-eds, but all of you are excellent writers, so I will plug them. But you had written a great op-ed in a paper, a newspaper in Shreveport. And I was just wondering if you could comment a little bit on your thoughts as well as your suggestions about what to do about that and how communities should address that issue.
Yeah, I think that until this point, we have not really appreciated the fact that childcare is essential infrastructure to our economic stability. Parents need to go back to work, but they cannot unless they have access to childcare. And I know I'm preaching to the choir when I tell you quality childcare is a triple bottom line investment. It not only keeps a workforce in a business, it contributes to household income when parents are making a good living, and it helps prepare children for school success. In our state, 70% of licensed childcare centers were closed on May 1st. What was already a crisis is magnified 100-fold. Prior to COVID-19, only 2% of at-risk infants had access to quality childcare in our state. So we really are faced with a terrible situation where that, need, the supply and demand just really do not match. So I think there's some creative solutions that communities can consider, especially if there is an excess of commercial real estate like there is in our community. That creates a great opportunity to partner with a childcare center. The cost of space is the second most expensive item in the operating budget of a childcare center. And many times that is an easy in-kind contribution that might be made. And that could be the tipping point for a business that is struggling to stay out of the red and continue to operate. So we know those profit margins for childcare centers are very narrow on the best day. And so under these circumstances, we've got to really think of creative, miraculous solutions, understanding that ensuring that childcare is in place allows our economy to continue to operate and certainly that goes without saying that needs to happen with safe guidelines.
One interesting way I think to sort of think about school reopening is thinking about it just from a basic reproduction number of the pathogen point of view. And so this RO number that I think many of us are familiar with, and really thinking of this number representing the maximum number or the maximum epidemic sort of potential of a pathogen. But this number, this RO number, actually you'll see has changed throughout the pandemic. And it's basically, it measures transmission potential. It measures transmission potential, but is based on factors like whether some people have immunity due to prior exposure from the pathogen or immunity from, in other cases, vaccination. And so again, that effective RO number changes over time. Other variables for the number are how long it takes for a person to be exposed to the virus, how long exposed to the virus to become contagious, so the latent period, how long an infected person is contagious, or the infectious period. And I bring that up for the school reopening because it really comes down to having more data, more seroprevalence studies. We really need local epidemiologic data, age-specific seroprevalence estimates. These, along with clinical outcomes, can really lead to estimates of the infection fatality risk, and that is critical in weighing the risks and benefits of different post-lockdown strategies. And then, recently there was an article that just had come out from China where they were looking at individuals who had recovered from SARS-CoV-2, and they had started to show a decrease in their neutralizing antibodies within 2 to 3 months after infection. So again, I think the data from this will start to provide guidance for the amount of children that have antibodies, what those antibody levels mean, and how that impacts the caretakers or teachers.
Thank you. Sabreen, you had mentioned, you'd kind of like started your talk talking about how there's so many downstream effects of what's going on with children in COVID-19. And it made me just kind of think about the fact that children always are an afterthought. They are an afterthought in research. We know there's so much less research on pediatric disease. There's so much less money spent on it. There is fewer advocacy efforts on behalf of children. The AAP is wonderful, but it's one organization, whereas there are many, many more lobbyists for other groups. There's fewer policies that relate to children. And then, children are an afterthought, but then even vulnerable populations within certain subgroups of children are kind of the last afterthought. And so one of the audience members, asked a question that I thought was good that I don't know if you want to take a stab at. Padma Swami wrote, how do we reach these vulnerable families, especially as the digital divide has increased? I don't know if you have any thoughts on that.
Well, I think others have kind of alluded to this as well, but if we're only starting to think about this right now at this moment in COVID-19, then we're too late. We're too late already reaching these families. So I think we have to build on the relationships that we already have with community organizations and with people in communities who are already in trusted positions. And I think Jyotsna's point about even just like at well child checks, really kind of targeting questions and screening, and not just sort of treating every person who comes into our clinic as sort of at the same, having been impacted the same, is something that we need to really keep an eye towards. One thing that I was kind of thinking about, just as pediatricians and like the power of social media, is when Kimberly was kind of talking about vaccines and kind of reaching different populations, is just the power of social media with, especially I think in this group, many of us being kind of parents. If we kind of, and if there's a move towards pediatricians or physicians in general kind of saying, and nurses and everyone in healthcare kind of saying like, I'm doing this for myself and I'm doing this for my child, that may have some power as well, sort of just to really get the word out there that it's safe. If we feel it's, once the vaccine comes, and hopefully it will be safe and tested. I know that that's a concern among many vulnerable populations, is how quickly this vaccine is being developed. And that was sort of this kind of history of mistrust with medical institutions, which is very, very justified if we look at our histories, whether or not this vaccine is actually going to be safe for the populations that may have like most mistrust in our institution. So us getting out there and really kind of promoting that this is safe, that we're doing this for ourselves, for our children, is something that I think could also go far.
Something else that I've been thinking about a lot is, there's the youth that we're talking about right now, but then there's also the, hopefully no one takes offense to this, but the medical youth, right? There's like the people that we teach. And so, Laura is doing an incredible job working with the actual teens that your organization is trying to help by letting them help you, essentially. And so I want to just kind of talk about the power of medical and nursing and kind of other allied health students that they have, but also the kind of responsibility that we have, I think, to educate them about this. You know, there's been a lot of really great op-eds recently about how the preclinical and clinical curricula don't talk a lot about a lot of this. And there was a great piece recently in the New England Journal by Rachel Hardiman, Eduardo Medina, and another fellow pediatrician, Rhea Boyd, called Stolen Breaths, about George Floyd, who we all now know, a Black American father who died from what they called a, quote, extrajudicial death sentence for an alleged offense that was never litigated or even charged. And they talk about a lot of things with structural racism. At the very end, they have 5 pointed actions for healthcare systems that we should be taking. The first one they say is that we should be divesting from racial health inequalities. And they kind of go into the insurance or the non-functioning insurance system that we currently have in the United States. They talk about desegregating the healthcare workforce. They talk about, this is one I want to talk about most, but quote, mastering the health effects of structural racism with professional medical competency, which is not one of the competencies listed in official medical education, and then to test it, not just to kind of pay lip service to it, but to actually, you know, say yes or no, you do or do not know this topic well. And then 4, mandate and measuring equitable outcomes, which I think speaks to the importance of evidence and numbers, like with Step Forward and with obviously what PHR does for a living every day. And the 5, to protect and serve our patients. So going back to the one about mastering the medical, the health effects of structural racism, I was just wondering if any of you from the medical side have any examples of what your hospitals or even just you personally are doing in the ED or in your clinic or with your hospitalist patients with your hospitalist fellows to kind of talk about this and address this.
I'll briefly kind of just speak about, I love that article and I think it's really kind of seminal work. So if people haven't read it, you should definitely read it. And I think we are using that article as kind of a framework to sort of build out a lot of ideas within our own division. And that's what I kind of encourage everybody to do when they look at this article. It's 5 really concrete steps or statements where you can kind of really build out specific actions towards trying to work towards more health equity and health justice. So we have a lot of ideas kind of floating around in our group, which I'm sure like many people do. And so we've sort of used the article to really organize those ideas and try to make sure that we're really paying attention to every one of those statements, those kind of 5 points in the article to move forward.
Kimberly or Jyotsna, do you have any kind of closing comments on that? And if not, I know it's very early. It was published a week ago, but or maybe a week and a half ago. But
no, I think it's a great, excellent, very important points that were brought up. And I think it actually speaks to another point of sort of geographic marginalization, which I brought up earlier, and I think it's vital to explore. Again, we know that housing policies are established on these, racially biased zoning. It's left communities of color living in these low quality housing that also propagates poor health. And so I guess my question is, if you see yourself, I would say this to those who are listening and our other physician colleagues, if you see yourself as a thought leader or, as a sentinel academician, it's a difficult question, but where are you serving now? How are you serving? For example, many of us pediatricians on this webinar, for example, have had subspecialty training, and subspecialty training typically occurs at larger academic centers. When we complete our training, in frank discussions with our colleagues, sort of few common themes surface from sort of recent fellow graduates. And this may be dramatized, but one frame of thought may be, I want to help people and that's all I want to do. I must serve the underserved. I empathize with them. I want to be their voice, or I come from a marginalized community and I want to give back to my community. So my question to the listeners would be, what do you think the majority racial distribution is of these physicians that are in these underserved urban areas? What does that mean? And does facing oppression in some personal way lead to empathy for others who are suffering, even if their suffering is different from their own? Another way that you'll hear recent trainees talk about, future plans. I want to help people, but I also really like academic centers. They have these well-built systems that are already in place, so I can engage when I have time in one of the following: research, quality improvement, curriculum development, clinical trials, or advocacy. I don't have any experience in these areas, but I think a large academic center fits my personality. I like the idea of being supported by all pediatric subspecialties. I want a job at the best place I can get an offer at. I'm personable, I love kids, I'm well-rounded, I went to a good school, and I already have 3 interviews at all the major academic centers in the city. Money's not that important, as I have some intergenerational wealth and my spouse can support us. This academic center is also in a poor neighborhood. This is a huge bonus because I feel good that I'm taking care of the underprivileged. So then my question to the chairs and of programs and directors, where change has to begin, is the health of Black or Hispanic and marginalized communities. How important is this to that applicant? I know I gave sort of a dramatized version of that applicant. And are you more concerned as an employer in where this applicant went to school, or how they have demonstrated their unwavering commitment to destroy structural racism? And I think that these are things that we need to start thinking about.
Thank you.
Katie?
Yes.
Hey, this is Laura. I do have a comment about mandating and measuring equitable outcomes. And I would go back to seeking the wisdom of the population that you intend to serve, and finding out, do they have access, number one, and what are the barriers to access? And then finding out from them, if they do have access, or once they do, what's the quality of their experience? Those are 2 things that are, I think, very important to measure and to really understand in order to truly change systems.
I absolutely agree. Thank you. This reminds me a lot, of empowering youth the way that they've done with gun control. I think it's really important to take the population of interest and let them be part of the solution, because they have most of the answers, frankly. Kimberly, do you want one last word?
Just briefly, I know we're running out of time. I could talk so much about this, as I'm sure we all could. We all are passionate, we feel the same, but I just want to say that before we as a medical institution, medical community can confront racism and discrimination, I think we have to do a lot of introspection and reflect on our own contributions to racism. And that's hard, but it starts with reading and learning and talking with others, and making sure we don't put attacks on our minority populations and physicians and staff who are confronting this every day.
Absolutely. Thank you. Thank you, all of you, for joining us. I totally concur with Kimberly that we could all talk for hours more. And I know we didn't get to a lot of your questions, but I want to hand it back over to Donna, and thank you again for this opportunity.
Oh, Katie, thank you so much. Thank you so much to the panelists. You were brilliant. And it was a really excellent discussion. It was far and wide ranging. I wish we had much more time. But you offered both practical guidance as well as really not shying away and addressing the much more complex issues such as structural racism. And to answer the first question that was asked today, are we discussing inequalities enough in the discussions of COVID? The answer clearly is no. So thank you for making it a centerpiece of your discussion today, including referencing the really important new piece, stolen breaths. So I just want to say to all of our audience members, thank you for attending today. If you would like to share this, you will find this on PHR's website shortly. You can view it there, share it, help build a community of human rights advocates at this unprecedented time. We're going to take a break next week, but we will return on July 10th at 1 p.m. Eastern time for a discussion on some of the unique impacts of COVID on mental health, and particularly focusing on vulnerable communities. So I hope you'll be able to join us then. And until then, thank you for your incredible support, your advocacy, and stay safe, everyone. Thank you.
Thank you.